Hi, good afternoon, everyone, and welcome to the TxRx community of Practice Echo. Please note that we are recording these sessions for future distribution. Anything listed in the chat does not appear in the recording. Your name may appear in the recording, so please know that you can change your name to your first name only if you would so prefer. My name is Shreya Prasanna, and I'll be facilitating today's session. A few quick announcements before we begin. To help us with attendance, please enter your name, affiliation, and email into the chat, which can be accessed by clicking on the speech bubble on the navigation bar at the bottom of your window. If you're one of our Abbie Ewell Texas providers, please make sure that you identify yourselves during this session. If you're joining via phone, please email your phone number and name to abbiewelltx@unisca.edu. Some housekeeping. Please stay muted if you're not speaking. If you've joined by computer, your mute button is on the bottom left of your Zoom controls. If you're on the phone, please press *6 to unmute and mute. We encourage everyone to speak at these sessions, especially during the discussion portion. We want to hear from as many of you as possible, so please keep your comments brief to allow time for others to speak up. Or if you'd so prefer, you can use the chat feature to share your comments and questions. Please note that no predicted health information is allowed in either the chat or the discussion. If you'd like to view closed captioning, please navigate to the bottom of your Zoom window and select the Show Captions option. Towards the end of the session, the Abbie Ewell Texas team will send out a link to an evaluation survey. All participants filling out the survey will be automatically entered into a raffle for a $30 Walmart gift card. Besides that, you can give us valuable feedback to help shape these sessions. Our didactic today is on a brief overview of alcohol withdrawal in the inpatient setting and will be presented by Dr. Abbie Ewell. Following that, we will discuss a case presented by Dr. Maram Baghi. We will start with introductions, followed by didactics, Abbie Ewell program announcements, case presentation, and open discussion. Thank you all again for joining today's Echo. We look forward to learning alongside all of you and encourage you all to share your experiences, questions, and insights in today's conversation. And with that, we will begin with some introductions. Dr. Ewell.
Hi, yes, I'm Dr. Abbie Ewell. I work at UT Southwestern. I'm an assistant professor of psychiatry here.
Thank you so much for joining us today.
I'm happy to be here.
Thank you. Dr. Waklu.
Hi, Siddharth Waklu. I'm a faculty at UT Southwestern, addiction psychiatrist by training, and the director of addiction services here at UT Southwestern and the addiction psychiatry fellowship director. Welcome, everyone. Thank you.
You so much for joining us. Dr. King.
Hello, everybody. I'm Van King. I'm an addiction psychiatrist as well. I'm a professor here at UT San Antonio and the medical director of Abbie Ewell, Texas. Welcome.
Thank you so much. Dr. Maram Baghi.
Hi, I'm Kapila Marambage. I'm an addiction psychiatrist at UT Southwestern. I'm the medical director for addiction services at the Parkland hospital system. Happy to join.
Thank you so much for joining us. Julie Parrish.
Hi, everyone. Julie Parrish. I'm a rehab counselor, licensed chemical dependence counselor. I'm the ECHO program manager here at UT Health San Antonio. Thanks for joining us today.
Thank you. Andrea Hebler.
Hello, everyone. My name is Andrea Havler, and I am the program coordinator for CSTEP. Welcome, everybody.
Thank you so much. And with that, we will begin with our didactics. Dr. Ewell, you can take it away whenever you're ready, once Karen shares the slides here.
Yeah.
And should I just say when to advance the slide, or am I able to do that essentially?
You'll have to just say next slide.
Okay. Well, I already introduced myself. I'm happy to be here talking with everyone. I hope to help teach and both learn today. So we can go ahead and advance the slide forward. I had initially misunderstood and was going to present a case but I think we'll just jump ahead to the actual material. I have no relevant disclosures, so we can go ahead and skip forward to the next slide. So these are just the learning objectives for today. So identifying the key symptoms of alcohol withdrawal, understanding the pathophysiology of alcohol withdrawal syndrome, which you'll see abbreviated as AWS throughout the presentation. Understanding common methods for assessing alcohol withdrawal, identifying some risk factors for complicated withdrawal, and understanding first and second line medications that we use to treat alcohol withdrawal. So next slide, please. So actually, let's skip ahead. I think 2 more slides to where it's alcohol withdrawal symptoms. 1 more. Yeah, great, thank you. So just to go through, I'm not going to read through all of these symptoms, but these are common symptoms of alcohol withdrawal, what to look for whenever you're seeing patients and suspecting alcohol withdrawal. It kind of starts with more mild symptoms and symptoms that you would expect to see earlier, like anxiety, insomnia, vivid dreams, nausea, vomiting. And then as the list progresses, you get to more serious symptoms of withdrawal, like you can see the hallucinations towards the bottom, disorientation, seizures. That's where we're getting into more complicated withdrawal. So and then to the right, you can see a timeline of what you would typically expect for alcohol withdrawal. Here it says withdrawal begins after the last drink, about 6 to 24 hours after the last drink. But it's important to keep in mind whenever you're treating patients that some patients who are consuming alcohol really heavily on a daily basis wouldn't go into withdrawal at a level of 0. They would actually maybe enter withdrawal even at a blood alcohol level of 100 or 200, depending on kind of what they're used to living at. So don't necessarily expect it to happen whenever the person has no alcohol in their system. It can certainly be well before that. And around 24 hours is usually when you expect withdrawal seizures to begin. Obviously not in everyone, but that's typically when that can happen. And around 48 to 72 hours is when most cases of very mild withdrawal are subsiding and cases of moderate withdrawal are peaking. And then around 72 to 96 hours, so much later, is when you would expect delirium tremens, which usually consists of hallucinations, disorientation, agitation, diaphoresis. So that's just kind of a timeline, and that's not exact, but those are the general numbers for when to expect what. So we can move on to the next slide. And this is based on, I don't know, I'll be curious to hear how many people use the CIWA, the Clinical Institute Withdrawal Assessment. This is for alcohol revised is what the AR stands for, but that's what we use here at Parkland Hospital to help us measure alcohol withdrawal. There are 10 categories of symptoms, which you can see displayed on the left. For each one of them, it's a score of 0 through 7, with the exception of orientation is 0 through 4. So you can get a max score of 67 whenever you add up the CIWA if someone was hypothetically positive for everything. Less than 8 is considered mild withdrawal. 8 to 15 is moderate withdrawal. Greater than 15 is severe withdrawal typically. So what this does, and we'll talk more about this, is this allows for symptom-triggered benzodiazepine dosing. So if a patient scores above a certain number or a certain cutoff, then they can receive benzodiazepines. That's as opposed to like using standing benzodiazepines regardless of the patient's symptoms. So, and it's just important to note that whenever you're going to use the CIWA or ask nursing to score a patient with CIWA, that the patient needs to be able to communicate and they need to be reasonably alert and reliable and cooperative in order for the nursing staff to assess using the CIWA, because a lot of the questions they ask the patient and they observe. There are other forms of assessments that you can use if a patient is delirious and not able to participate in the CIWA. So we can go ahead and advance to the next slide. So this is just an overview of the pathophysiology of alcohol withdrawal. This is a big simplification of it, but it's just really important, particularly whenever we get to the pharmacological treatment of withdrawal, to keep in mind what we're dealing with. So GABA is the main inhibitory neurotransmitter in the central nervous system, and glutamate is the main excitatory neurotransmitter in the CNS. And typically, whenever a person is in homeostasis, which is the top picture on the right, where our bodies like to stay, GABA and glutamate are even, and a person is, doing okay. And then if a person consumes alcohol just occasionally, goes out and has some drinks, then the alcohol kind of contributes to the GABA side. The person gets acutely sedated. So you can see the GABA goes down because that's taking more of an effect than the glutamate at that point. But whenever you have chronic and regular alcohol use, what happens is the body likes homeostasis and it's going to compensate. So glutamate is going to be upregulated to kind of match the GABA in the body combined with the alcohol. So that would be C in this chart. And then all of a sudden, if a person that's typically drinking alcohol pretty heavily stops drinking, they enter a withdrawal state where that alcohol is no longer there and the glutamate has been upregulated. So they're in an excitatory state and their autonomic system is overly active. And so that's what we're dealing with whenever we're dealing with acute withdrawal, is the person has too much glutamate and too little GABA. And so that's something that we can think about whenever we're looking at medications for treating alcohol withdrawal, keeping this kind of seesaw in mind and what to focus on. So next slide. So here is the how to assess for if a patient may have more complicated withdrawals, such as seizures or delirium tremens. This is just one way to assess that. This is called the Prediction of Alcohol Withdrawal Severity Scale, or PAWS. We don't necessarily have to read through all the questions, but I do think it's important to note some of these you may not routinely ask a patient, like, have you ever experienced blackouts? But some of them are pretty obvious, like, have you ever had seizures or delirium tremens before? Another one that you may not think to ask is if a patient has combined drinking with benzodiazepines or barbiturates in the last 90 days. And you can just go through this. We use this routinely as we assess patients to help us understand who may be at higher risk of complicated withdrawal. A score of at least 4 or greater indicates that the person's at moderate to severe risk of complicated alcohol withdrawal symptoms. And the sensitivity and specificity is actually pretty good for this this PAWS scale. So I put that on there. So that can be used just to kind of help guide you in how aggressively to treat the patient from the beginning. So next slide, please. So in terms of pharmacotherapy for alcohol withdrawal, benzodiazepines are considered the first line treatment and the gold standard for alcohol withdrawal. What they're doing is they're stimulating GABA and they mimic the effects of alcohol. So if y'all remember from the previous slides where you have the alcohol withdrawal state and there's too little GABA on the side of the seesaw and too much glutamate, you're stimulating the GABA to help improve withdrawal symptoms. And benzodiazepines have proven efficacy in preventing complicated withdrawal and reducing the risk of seizures. There's a relatively wide margin of safety compared to, say, barbiturates years ago, which we'll talk about again. And then there's also a low potential to develop dependence, especially in the short-term period that we're often using the benzodiazepines for in the hospital. In terms of the choice of benzodiazepines, this is something I'll be curious to hear people discuss, but there's really no consensus on one benzodiazepine being superior to any of the others. The ideal benzodiazepine would be something that had a rapid onset, but a long half-life and didn't require metabolism by the liver, but we don't really have one, at least in our access, that's like that. So and we can kind of talk about the pros and cons. I have a chart in the next slide once we get to that. But typically, you do want something with a longer half-life like diazepam or Valium or chlordiazepoxide or Librium that can produce a smoother withdrawal because it has a longer half-life and can taper itself. But whenever you have patients with advanced liver disease or elderly patients, you might want to choose a shorter acting benzodiazepine so that you don't get excessive sedation or respiratory depression because either the patient has like liver disease and cannot process the medications appropriately. So there's different ways that you can schedule the benzodiazepines for detoxification. One would be the symptom triggered regimen, which is what we looked at earlier. An example of that would be using the CWA scoring. So just whenever a person scores above a certain threshold, you administer a benzodiazepine. Like at our hospital, we have the CWA linked with Ativan. So if a person scores above an 8, they get 1 milligram of lorazepam. Depending on the score, you go up on the dose. Another type of regimen for detoxification would be a fixed tapering dose regimen. We often do that in combination with the symptom triggered regimen. So that I just gave an example of that. Say you would start a patient on diazepam 10 milligrams 3 times a day, and then the next day you would go to 2 times a day, and then the next day daily. There could be a lot of variation in that, but that's just a basic example. And that would be regardless of what kind of symptoms the patient is showing. You would administer the benzodiazepine. And then less commonly, I would say, but I'd be curious if other people use this often, the loading dose regimen, where you use a longer acting benzodiazepine in a very high dose initially with the idea that it's going to taper itself over time. So an example of that would be using Librium or chlordiazepoxide around 100 milligrams Q 1 or 2 hours until sedation is produced. And then the idea is that it would taper itself. So those are just different options. And it doesn't mean that you just have to choose one. You can choose multiple of those. Like I said, we often do the fixed tapering dose in addition to the symptom trigger regimen here. So next slide. So this is just comparing the different benzodiazepines whenever you're thinking about what benzodiazepine to use or which benzodiazepines to use for what patients. It's important to take into account lots of different factors. One factor would be the route that the patient can take the medication, or the route that you want to give the medication. So Ativan or lorazepam and diazepam are the two that come in various routes. So you can give them by mouth, IM, IV. The diazepam, I just put an asterisk because the absorption is erratic through the IM route. The equivalent doses are listed there. There's some variation in the literature about exactly the equivalency, but that's the numbers that I saw in most of what I looked at. Also, just thinking about the half-life of the medications is very important. So as you can see, the half-life of the lorazepam is typically much shorter. The half-life of Librium or chlordiazepoxide is shorter, but it's important to keep in mind kind of two below there, it's the half-life including the active metabolites. So some of these medications have active metabolites. The diazepam and the chlordiazepoxide have active metabolites. So that makes the half-life of them much longer actually in reality. So that's important to think about. Are you wanting to treat the withdrawal sort of longer term, or do you want something short that you can have more control over and then reassess the patient and decide if they need more medications? The more lipophilic medications, I go through those, the main one being diazepam, have a much more rapid onset. So that can be really important whenever you're dealing with a really sick patient that needs medications right away and you want it to start working very quickly. Diazepam is the most lipophilic of the ones listed, and so it has a very rapid onset. And then another really important point would be how these medications, these benzodiazepines, are processed in the liver. The oxazepam and lorazepam are preferable in liver disease. undergo glucuronidation versus diazepam and chlordiazepoxide have a longer half-life in the liver because they require metabolism by the liver and because they have the active metabolites that require metabolism in the liver. So we can also discuss, because I know a lot of people have kind of different ways of deciding when do you do lorazepam versus diazepam, depending on liver disease. So I'll be curious to see what people say about that. And then moving on to the next slide. Please, thank you. So this is just additional pharmacotherapy for alcohol withdrawal. I wanted to make sure and mention barbiturates. Phenobarbital specifically would be the preferred barbiturate if you're using barbiturates due to its rapid onset of action and long half-life. Over the years, benzodiazepines have gradually replaced the different barbiturates for use in withdrawal, but more recently you're seeing that barbiturates, particularly phenobarbital, has been regaining use. And there's multiple reasons for that. One I didn't include on here, but I should have, is that thinking back to the mechanism of alcohol withdrawal, phenobarbital actually can help to suppress glutamate. So it not only can help with GABA, but it suppresses glutamate. So it kind of works on both sides of that graph. And also phenobarbital works synergistically, but with the benzodiazepines, it binds at a different site on the GABA receptor to increase the flow of chloride and increase the channel opening, versus with the benzodiazepines, it binds in a different location, and the benzodiazepines typically increase the frequency of the channel opening versus the duration. So it kind of works in a different way, and it can work synergistically. Phenobarbital can be used to rapidly control withdrawal in patients that aren't responding to benzodiazepines. It has a very long half-life, so it can self-taper. And but a downside would be, which is kind of why we developed the benzodiazepines, the narrow therapeutic window, and a concern for respiratory depression is important to keep in mind. There's mixed studies on the use of phenobarbital, and some of them have shown reduced length of hospital stay, reduced amount of Ativan or lorazepam that patients need, and no increased adverse events. But there's also studies that aren't so positive, so there's kind of mixed results right now. But we do use phenobarbital here at Parkland sometimes whenever people have withdrawal that's just not responding to the benzodiazepines. So next slide, please. So these are just other second line treatments for alcohol withdrawal. Of course, the benzodiazepines are first line. There's also anticonvulsants under that category. Well, I should say the anticonvulsants have been shown obviously to decrease the risk of seizures. Also, they've been shown to reduce cravings. Typically, they are less sedating than benzodiazepines. And there's also some evidence that they may block kindling in the brain cells. So, which is kind of like the worsening over time of withdrawal each episode that a person has. So there's some evidence of that. A commonly used medication is gabapentin, and I won't read through each thing on these, but one advantage to the gabapentin is that it's renally metabolized and fairly well tolerated for most patients. So you don't have to worry so much about the liver disease with gabapentin. It can particularly help with sleep and anxiety in my experience. So we often add it on to benzodiazepines whenever people are in withdrawal. Carbamazepine or Tegretol also has proven efficacy in alcohol withdrawal. The big issue with that, well, two big issues, is everyone I think knows it has a lot of drug interaction, so you have to watch out for that. And then it's also primarily metabolized in the liver, so just being aware of that whenever you're looking at the patient and if they have liver disease. Valproate or valproic acid also falls under this category. It can potentially protect against worsening severity or have the anti-kindling effect. I find it particularly helpful to add on whenever patients have acute agitation and a lot of restlessness. It can help, and obviously also for seizure risk, it can reduce that. But again, it's important to be aware of liver impairment being an issue with that. Topiramate is another one. It enhances GABA activity. It can also inhibit glutamate and reduces hyperactivity that and the anxiety that are often associated with alcohol withdrawal. One that people may not be as used to seeing considered in the withdrawal category is acamprosate or Camprol we use sometimes to help both with relapse prevention, but there's also studies showing reduction of alcohol withdrawal symptoms, particularly like hyperactivity and the hyperarousal associated with withdrawal. Baclofen would be another agent that could be used and is sometimes added on. It's a GABA B receptor agonist, so it can reduce the severity of alcohol withdrawal. And it's another one, like many of these, that could also be continued post-withdrawal to help with alcohol use disorder. I just wanted to mention, I put neuroleptics there, not because those are typically recommended as additional medications to add on, but only if a person is really severely agitated and not responding to benzodiazepines or other forms of treatment that we've talked about, would you consider a neuroleptic like Haldol? They can actually increase the seizure risk. And then there's many medications that we know have shown promise, and there's a lot of research out there right now on medications such as ketamine, sodium oxybate, and I always say Precedex because that one's hard for me to pronounce, but there's a lot of studies going on right now looking into what else we can use to treat alcohol withdrawal. So I think that's the last slide. Yeah, that's just, yeah, okay.
Thank you so much, Dr. Ewell, for the wonderful presentation. And we'll now open up the floor for any questions.
Dr. Ewell, that was excellent. That was a great presentation. On the adjunct medications, what about ketamine? Has on the Parkland service, do you try ketamine for patients or?
I haven't done that. I haven't tried it yet. I just was reading about studies of it, and I've heard a lot of positive things, but yeah, I haven't done that. Do you have experience with that? Or?
No, I was wondering whether if patients in the MICU and all, if that's been an option either by the MICU team or by or a recommendation by you.
No, and actually come to think of it, I would say the MICU I most commonly see. We had someone just today that they had them on Precedex or Versed, but I haven't seen anyone yet where they just went for the ketamine for that. So,
okay. Yeah, thank you so much. Great presentation. Loved it. Yeah.
I see a question here on the chat from Chisholm. At the point where the body starts overproducing glutamate, is that where addiction is normally indicated?
Sorry.
So I can repeat it.
Yeah.
At the point where the body starts overproducing glutamate, is that where addiction is normally indicated?
Oh gosh, that's a really hard question. That would be really hard to know. That's an interesting thought. You know, I don't know that there would be a way to like measure that or know that. And I suspect, you know, that's why we use a lot of the things that we do to like the DSM to diagnose addiction, but from like, I don't know, on a biological level, if that would be the exact point or how you would exactly measure that. I don't know if anyone else has thoughts on that.
Hey everybody, Crystal Walker. Sorry I was a few minutes late, guys. But excellent presentation. I thought that it was fantastic. But in my thinking of that question, you know, tolerance and withdrawal would likely be associated with the upregulation, right? Because then you're having physiological changes and you may experience withdrawal symptoms or increased tolerance. But that, when we look at the DSM-5, doesn't necessarily mean you have developed a substance use disorder. Mm-hmm. So you have to look at all of those other psychosocial elements mm-hmm. and how it's impacting your life in general. So I wouldn't want to go too far down the rabbit trail of this one physiological change equaling addiction. So just to put it into that perspective.
Yeah, very true. No, that's a really good point. There's so many other factors too that we look at for that. Yeah.
I see another question here in the chat from Neville. How would a layperson know that benzodiazepines are not working for the person?
I think kind of what I see is, okay, we've administered this, whichever benzodiazepine it is, and we're administering it again and again, and I'm seeing no changes. Like, this patient's vitals are still bad, or they're still diaphoretic, or they're even getting worse. We're still looking at all these symptoms of alcohol withdrawal that I listed, and there's just been no improvement in those symptoms. So there are cutoffs in the literature, like for what they consider to be a failure of the benzodiazepines. There's some disagreement about it. I wrote it down, but it's something about some people have put like 50 milligrams of Valium in 1 hour, or over 200 milligrams of Valium in 3 hours have been used in some papers to say, okay, this person has failed the benzodiazepines. But more often than using that, I can't think of a time that I've used those actual cutoffs.
Healing and
It's
cults
just
of the
a-
ancestors from Nzambi A. Mpanguna.
It's just the lack of response to multiple doses. So does that kind of answer that? Or-
Yeah, and I thank you so much. And I see another question here. Can resentation also apply to ambulatory withdrawal and indicated medications and protocols?
I think so. I don't do that as much, but I do know that sometimes people actually can use the CWA to decide about inpatient versus outpatient treatment would be one way to apply that. Like where you see the scores of less than 8, typically those patients could potentially be managed outpatient. And then the scores up to 15, it kind of depends on if the patient has comorbid issues, say the patient is pregnant or the patient has liver disease, something like that, that adds a complicated level to their withdrawal. You might consider inpatient for that person, but anytime someone's scoring over 15 on the CWA, you tend to think this patient definitely needs inpatient treatment of their withdrawal. So that would be one correlate that I could see. But I don't work in the outpatient setting a lot. I'm basically all inpatient at this point. So
I would also recommend adding your predictive scale as part of being able to anticipate how severe the withdrawal may be, and do they have a history of seizures, and do they have a history of major complications, or are they currently pregnant or have a major medical issue that would complicate the withdrawal, and things of that nature, to categorize them in addition to using the CWA score as well, and using both of those to determine if they're appropriate for outpatient or inpatient.
yeah, that's a really good point. Anyone scoring high on that predictor of alcohol withdrawals, that's very concerning for someone that probably shouldn't be managed outpatient. So.
Thank you so much. And this was an amazing presentation and a discussion. In the interest of time, we will move on to our next part of our session. Thank you again, Dr. Ewell, for your presentation. Karen, if you could please share the announcements. The Center for Substance Use Training and Telementoring CSTAT provides high-quality education to healthcare providers. CSTAT makes evidence-based practices available to addiction specialists in Texas and the U.S. with sessions like the one you are attending today. For more information, visit bwelltexas.org. Next slide. To claim your CME credits, you must text by midnight tonight. Text attend 10095046 to the number you see on the screen. We will be sharing this information in the chat as well. Next slide. We are launching a brand new ECHO tomorrow. This Recovery Science ECHO program is a research-focused ECHO which will help grow a diverse workforce skilled in conducting recovery science research. We will be meeting every third Wednesday of each month. Please do join us. This is going to be an exciting ECHO to join. Next slide. Join us for our second Texas session of the year on Wednesday, November 15th. To register, please visit texas.org sessions. Next slide. Save the date for our annual Texas Substance Use Symposium, which will be taking place on February 29th and March 1st in Austin. Registration will be opening very soon. To learn more, please visit texas.org. Next slide. And finally, our next session for TxRx will be on Tuesday, November 21st. Please do join us. It will be an interesting one. And with that, we will move on to the case. Karen, if you could please share the case, and Dr. Marambage, whenever you're ready, you can take it away.
Hi, I'm here.
We are not able to hear you, Doctor.
Can you hear me now or no?
Yes.
Okay, I'm sorry about that.
Mhm.
So I'm Kapilam Marambage. I'm the I'm an addiction psychiatrist at the Parkland Hospital along with Dr. Ewell. I'm the medical director for Parkland. So I want to discuss this case briefly. This is a 29-year-old Caucasian female who came in really with a kind of an overdose situation with shortness of breath.
Dr. Marambage, are you still here?
Yeah,
Yes.
I'm here.
Okay.
Something happened, yeah. So anyway, so the patient is a 29-year-old female who came in with shortness of breath and reported that she has used opiates and also some stimulants in the form of methamphetamine. And when she came in, we did a urine drug screen, and she was positive for opioids, fentanyl, as well as amphetamines. And so the questions and concerns I like to discuss in this case is how to evaluate for fentanyl in the system and how to manage the buprenorphine induction if fentanyl is positive. So the details of the case in brief is that she is mainly an opioid use disorder patient by the DSM-5. She has been using black tar heroin for approximately 10 days, but it preceded the back issue for which she was started on opiate pain medication and ultimately, went into use of heroin and then intravenous heroin. More recently, she has started using methamphetamines so that she can not kind of fall asleep with the heroin. And but she did not know that she was knowingly using any fentanyl. So this time around, she used a batch of some sort of mix of fentanyl, of heroin and methamphetamine, and then she kind of not fully overdosed and kind of complete respiratory depression, but she developed shortness of breath and some kind of difficulty breathing and altered mental status and brought into the hospital. And we did the urine drug screen, as I said, and found amphetamines, opioids, and fentanyl in the system. Can you bring it down a little bit more? And so she has had a history of, being on methadone and also buprenorphine in the past, and she was preferring to go back on the buprenorphine for the ease of, follow-up, that she cannot make it to a methadone program on a daily basis. So she also had a history of anxiety and depression, some elements of post-traumatic stress disorder in the background. So the question is, now that the fentanyl is positive and the patient soon, she was given some Narcan Narcan was given at first, and then subsequently she started going into some level of opioid withdrawal. And now the question was, of course, all the criteria were met for both opioid use disorder as well as stimulant use disorder. Eventually, we were able to, get her on Prozac and buprenorphine, but the initial challenge was how to do the induction. Now, of course, we have come out with certain protocols, but I wanted to hear from this forum, what are their ideas, how they would think about this, and how would you do a buprenorphine induction on a patient, like soon as they go into withdrawals and start reporting withdrawals. What is your strategy for the induction was my clinical question. And I don't know, Shreya, is that the way we will go, that we will ask the question and expect the forum to answer? Or
Yeah, I think that's fine. I mean, we will open up the floor for any questions or further, questions about the case, or and we can go from there. It's usually pretty organic. So
okay.
Thank you so much for presenting.
Also, I'm sorry, I forgot to mention she had infective endocarditis also, which was discovered in the hospital. Subsequently, we did some interventions. The long story, she was here for a little while. We did some cardiac surgery also in the end. So, anyways, the induction was the initial problem. How are we going to deal with this? So, first, before we get to that, are there any questions about the case?
Dr. Muramji, one thing in general I would like to say is when we talk about fentanyl inductions, we just assume that all the fentanyl in the illicit drug market is the same, which we don't know, because the fentanyl comes to the country from different sources, and we just assume. So before you discuss the microinduction protocol that you use at Parkland, which really works beautifully, the inductions that I've done as an outpatient, and again, we're talking about two different populations here. Your population is quite different from, is I have just used the standard, the 4 milligrams, and most of the time it has worked out pretty well. But again, my patients also, I tell them, I said, just make sure that you really think you're in withdrawals from so my patients have waited for 3 to 5 days before they have taken the first, and I tell them, I said, you may want to start off with 2 milligrams rather than the 4, but some of them have started with 4 and have done well. But there are other some colleagues of mine who start with 4 and people you have induced to withdrawal. So that's why it becomes so complicated, the fentanyl induction. So just wanted to share my outpatient experience. Of course, like I said, we are dealing with clearly different populations, and the level of opioid use disorder severity is quite different. Yeah.
One thing I was wondering as well, excuse me, is there any pain that needs to be managed, or is that not the major thing? Because if she needs full agonists for some pain control, then that's going to also complicate the buprenorphine treatment.
Yeah, so let me answer those two points or the questions. Firstly, about Dr. Vaklu's case, this is a little different population, like you mentioned. In our case, sometimes we don't have the liberty of keeping the patient for 3 to 4 days. The medical teams will want to discharge within 2 days or 3 days. They will not, opioid use disorder is not a criteria for them to maintain admission. And if you want to keep for that long for the fentanyl to kind of leave the system, most of the time our experience has been that the patient will bring some heroin or fentanyl into the hospital and use in the hospital, or they will leave against medical advice. So defeating the big, like in this patient's case, the patient wouldn't have gotten IV antibiotics or gotten the cardiac surgery required and all that. So we had to come out with some plan that on the day 2 or day 3 that we have to induce the patient. And for that, we have come out with microinduction is one thing, but then we have some modified induction protocols. To answer Dr. King's question, the pain management, very important point. So that is actually a rescue point for us. Like if there is a pain issue involved, then we can keep the patient on short-acting pain medications for a little while and address the opiate cravings or whatnot that will tend for the patient to leave the system. That way we can give a bridging short-acting opiate protocol until the fentanyl leaves the system in 3 to 4 days or something, whatever the estimate that we make. And that estimate is made based on how big the use is. Like if they're regular fentanyl users, then we might need a little long. Whereas as in this patient's case, this patient did not get the fentanyl through the heroin. She got the fentanyl through the methamphetamine. You know, what we have found is that quite a lot of methamphetamine in Dallas is kind of cut with fentanyl. So we have some data, which I don't want to go into right now, but you won't believe we have started doing norfentanyl levels in urine testing. 80% of our addiction patients who come positive for, drugs, opiates plus methamphetamine are positive for fentanyl now. So it's a big problem. 80% plus. And then most of it is not even coming with heroin. It's coming with the either pills like, Norco or something, which is not even Norco. You don't find opiates in that at all. And then it'll be fentanyl or the stimulants. So good question, Dr. King. What we do is we do a short opiate taper or opiate pain management, and then go and do the buprenorphine induction later.
One thing I was wondering is, it sounds like the patient inadvertently, as you described, got into fentanyl. Her drug of choice was not fentanyl. In the acute setting, if she had been resuscitated with naloxone and she was in acute withdrawal, one method would be to overcome the immune receptors with higher dose buprenorphine, get her covered, start with 16, add 8 as needed. And once you've got the withdrawal symptoms from the opiate under control, she's protected somewhat if you are able to discharge and follow up in clinic with a prescription for buprenorphine over a few days.
Yeah, that's absolutely right. We have that as one of the protocols. We have 4 different protocols. What you described is one that we will give 16 followed by 8 and maybe 8 BID or 8 TID after that, which we do only for patients without any major medical complications. Now, in this patient's case, she had some heart failure also as a result of the endocarditis. In such a patient, I did not do that protocol. We did a different protocol, which we gave like 4 and then followed by 8, without giving a large dose all at once, because sometimes that might be questionable in a patient. So we are a little careful because, in our world, in the addiction consultation service, if something goes wrong, whether we can argue all we want that it's a partial agonist antagonist, but it'll probably be labeled on the buprenorphine due to lack of experience in a lot of people. So we don't want to do that big dosing. That is done for people who are done, seasoned fentanyl users, regular fentanyl users, but generally fit otherwise, no medical issues. Then we do the 16-8-8-8. Yeah, great point. Thank you. So just to summarize, we have low dose inductions. Like in some patients, we give 2 milligram dosing, like how Dr. Vaklu was talking about, 2 milligrams about 1 hour apart, like 4 doses, and then followed by maybe 4 milligrams TID or 8 milligrams BID, something like that. And the second protocol is what Jim was just talking about, the 16-8-8 protocol. Another protocol is what we use for this patient, which is 4 and then 8 BID, 8 TID, something like that. And then in some cases, the one that Dr. King was alluding to, where we will do pain management. Sometimes if the patient needs longer term pain management, we do microinduction. Microinduction is done with Belbuca. Belbuca is a sub, it's a buccal preparation of a pain preparation for buprenorphine, which we will induce. We will, do a cross tapering between short-acting opiates and Belbuca. And then eventually in about 4 to 5 days, we convert to buprenorphine. And I am happy to, I think somebody has requested, I think Jim has requested the protocols. I'm happy to send it over to somebody who can share it. So that's, I think, what I have.
Thank you so much, Marambage, Dr. Marambage. I'm just gonna open up the floor for any more questions or comments or any similar experiences that the community here would like to share.
Could you go through the rationale for the high dose buprenorphine induction? I haven't used that myself, but it is So what's the scenario where you would consider using that?
Yeah, so the criteria that we use is like, let's say it's not this patient, though. This patient is a inadvertent kind of, she got it through the methamphetamine. If somebody comes like medically, good person, no medical complications, a fit male or a female for that matter, without any other problem, but they are seasoned fentanyl users. They have been regularly using fentanyl. Now they are clamoring to get on something. Otherwise, they are threatening to leave or something. We know that the fentanyl is positive in the urine. It hadn't been 48 hours, even 48 hours has elapsed, or just 48 hours have elapsed, right? 48 hours since the last use of fentanyl. Still, possibly fentanyl is in the system because it's deposited in the fat. So it keeps coming. So what we do is we give this the bigger dose of 16 milligrams of buprenorphine, which will kind of occupy most of the opiate receptors and prevent any fentanyl from coming in and occupying anything. So the 16 milligrams is given so that it is a full saturation of the system, so that the fentanyl cannot come, because it has a bigger affinity to the receptor. After that, we give another 8 so that even some fentanyl came, it get kicked out. And then after that, it's fine. We have found, we have run this protocol as a pilot for a lot of patients, and we haven't published it yet, but we have had like almost 90% good results. Very little instances of precipitated withdrawal. So
Yeah, there was, I agree. There was the case report, I think Herring and the group out in Highland Hospital basically compared higher dose inductions with lower dose induction. And this is through the emergency department mostly, but also they have a bridge program, and they did not have any adverse outcomes with the higher dose. In some ways, if a patient is in acute withdrawal, the quicker you can get them out of it, it would seem to be more amenable, especially with fentanyl and the ubiquitous nature of it. It almost seems, at least in my situation, the emergency department going with a higher dose first and adding until you've completely saturated the receptor gets someone out of withdrawal quicker, and therefore perhaps a better experience overall. I'm wondering with somebody that in this case the patient had a heart condition, what was the rationale for going slower? Are we worried about cardiotoxicity of the buprenorphine?
No, not cardiotoxicity. We were worried about the general respiratory status of the patient, that if we give a large dose, and it might be the buprenorphine, it might be something else. If something were to happen to the patient, there is a tendency, because of lack of experience, and we cannot convince them otherwise, that they might blame it on the buprenorphine. And so we didn't want to do the high dose induction for this patient. The patient had so many problems, like the autonomic stability was not good. And the patient was in a hospital kind of surgical setting, not like the emergency room. In the emergency room, the higher dose can be done much safer because you all are equipped to manage acute, issues much better than sometimes the general flow. So I'm a little careful how I manage the patients, because we are a long kind of, they trust us to not do stuff that will compromise patients or end up putting the patient in the ICU or something. So that was the rationale. There's no real medical rationale to it, but it's just, kind of keeping all boxes safe, Thank you for all the questions. It's wonderful. Thank you.
Thank you all so much. And thank you, Dr. Marambage, for presenting this case. I wonder if anybody has any additional comments or insights they would like to share.
So I did have a question, and it was raised somewhat with this patient who, is seeking methamphetamines or had been using and inadvertently got in. In terms of harm reduction and how frequent opioids, fentanyl, are found in methamphetamines, is there any experience with almost preemptively putting people on buprenorphine, even though they're not seeking fentanyl, they're seeking methamphetamine to protect them from fentanyl overdose?
You're talking about pure methamphetamine users without any opioid use disorder?
Any kind of methamphetamine user that is putting themselves at risk for fentanyl, especially, as you said, in Dallas, it's a high percentage that has fentanyl in it,
Right.
just as a harm reduction or protective measure.
We haven't had that practice where we will start people on buprenorphine when they don't have an opioid use disorder, but a purely stimulant use disorder. But when we want to address a harm reduction approach for such patients, what we do is we will let the fentanyl leave the system and get them started on naltrexone and Withdrawal combination, because that has some proven benefits for stimulant use disorder. So and then naltrexone will protect the patient against the fentanyl, hopefully. That has been our approach.
Yeah, that makes a lot of sense. Oh, thank you.
Yes, Lindsay, I have a question.
Yeah, and well, it's more of a comment. So I just wanted to say that, like, I work a lot with harm reduction groups, and I think there's a lot of almost fear mongering going around with fentanyl. Like, it's really, if you look at the data for it, we do a lot of drug testing things. There's not that much fentanyl in methamphetamines. There's a website called drugsdata.org that has people send in their samples from all over the country. And if you look at it, there's like maybe one that has fentanyl in it. That's just meth. So generally speaking, if people are using purely methamphetamines, it's not that high of a risk. But I still like to give out Narcan, sorry. I still like to give out Narcan just because you never know, and you don't know who you can be around necessarily, so it's good to carry it on you.
Yeah, the sample that we had only about maybe, cannot remember the numbers anymore, maybe 60, 70, 80, we haven't published that, but that had about 40 to 50%, I would say. It's just pure stimulant use in Dallas.
We had a patient come in the other day that swore that she did a line of cocaine, and she only tested positive for amphetamines and fentanyl, and she was just baffled, so it was completely different than what she expected. So
I had put in the chat, I had a client who every once in a while will abuse Adderall. And she took an Adderall from a friend who had a script for it, she said, and tested positive for fentanyl. So she knew she was going to test positive for amphetamine, and she was prepared to deal with me on that. When I told her about the fentanyl, she hit the floor. She said, I had no idea. And that's why we talked about the dangers of the tainted. You don't know what you're getting. So it's in Adderall as well.
Yeah. So at my treatment center, I have 680 patients. 1 in 3 persons who are actively using amphetamines are testing positive for fentanyl. And out of those 1 in 3, they do not know they're using it. Not only do you have the psychological effects of the amphetamine, but you have the physical effects of the fentanyl, meaning that you're going to want more, or you're thinking you want to want more methamphetamine, and it's really the fentanyl you're desiring. So they're going back and forth. So
she talked about going into withdrawal and couldn't figure it out. She said, I knew I was feeling something strange that was different, that had nothing to do with the Adderall. And I said, it was the fentanyl, because she's on bupe. So of course it put her in precipitous withdrawal, and she had no idea how she got there, thinking she was taking Adderall. Yeah, and that's pretty common with heroin users too, where they're like, I know something was off. I didn't know I had fentanyl in my system. In the winter, I was sick a lot sooner. Didn't feel right to me. And then of course, when we tell them when their drug screen comes back, hey, you tested positive for fentanyl, a lot of them actually act surprised. And then there are ones that are actively using fentanyl, but that's still pretty rare here in San Antonio, I know.
Thank you for all that. How many patients you said, Christoph?
I have 600 methadone patients, and about 11 buprenorphine patients.
Yeah, so that we were surprised too. We didn't want to believe this at first, but it's quite a lot, and it's surprising.
Yeah, it's the new drug trend, actually.
Thank you all for this awesome discussion. And in the interest of the time, I will request Dr. King to please summarize some of the recommendations for Dr. Murambage.
Well, this was a very interesting discussion that we've had today. Bringing together some threads for some other presentations I think that we've had recently as well. But I think it was very interesting to hear about some complications of alcohol withdrawal, some specifics that we wouldn't necessarily, many of us that are mostly outpatient don't really get that much exposure to, but it's certainly good to know. And then talking more about these different ways, strategies of getting people treated with buprenorphine in order to help them, not only inpatient, but I think some of these things are strategies we could even consider using outpatient. Very, very interesting echo today.
Thank you so much. And thank you all for joining today's session. As a reminder, to earn Z credits, please text the activity code 10095046 to 844-502-1338 by midnight tonight. We also request you to complete the post-session feedback survey using the link in the chat. The survey link will be open for 1 week. If you would like to present a case, please email bvaltx@utasca.edu. We look forward to seeing you at our next session on Tuesday, November 21st. And remember, tomorrow we are launching our new Recovery Science Echo at noon. So please try to join us. It's going to be an interesting session. Thank you all and have a wonderful rest of your day. Bye-bye.